Hello, everyone, and welcome to McGill Cares, a webcast series supporting family and informal caregivers. I'm Claire Webster, a former caregiver, certified Alzheimer care consultant, and founder of McGill University's Dementia Education program. I work with a dynamic team of leading healthcare professionals to oversee the program, who include Dr. José Moret from the Division of Geriatric Medicine, Dr. Serge Gauthier, Professor Emeritus, formerly of McGill University's Research Center for Studies in Aging, and Dr. Gerald Fried, McGill Steinberg Center for Simulation and Interactive Learning. These webcasts are made possible thanks to the generosity of donors, and I would like to thank the Zeller Family Foundation for sponsoring today's webcast. Today, we will be discussing the topic of understanding responsive behaviors in people living with dementia. My guest is Dr. Doell. He practiced geriatric medicine at the McGill University Health Centre and is an assistant professor in the McGill Faculty of Medicine and Health Sciences. He was recently appointed medical director of the Ingram School of Nursing, Advanced Practice Nursing, Adult Care. Dr. Doell is particularly interested in dementia care and has worked with many of the leading experts in neurology, psychiatry, and geriatrics in Canada. He will give a presentation that explains challenging behaviors caused by dementia and provides insight into how they can be addressed. Welcome to McGill Cares, Dr. Doell.
Thank you very much, Claire. I'm happy to be here and look forward to sharing some knowledge and information with everybody. I hope it's truly helpful. So welcome everybody to the talk about behavior. We are the Dementia Education program, so it's reasonable to think that we're going to be talking about behavior associated with dementia, but in this talk we're going to be going beyond dementia in a way, and I'll explain that a little bit later. We're going to try to define what behavioral issues are associated with dementia. You're having a physician talking, so of course we're going to talk about drugs, but my job is to try to present as honestly as possible the real situation about drugs, the role that they do have, but also knowing the limitations that drugs have as well. And I spend a lot of my time trying to encourage people to think about alternatives to drugs when it comes to looking after behavior symptoms in dementia. There's a lot to cover. So you may find that you need to rewind and play again or come back to the talk. That's okay. You don't have to get it all in one shot. And many of these topics are discussions in and of themselves. So this will provide an overview, a basis for further reading or further discussion later on. So in Quebec, we call this topic SCPD. And I hear something PD, I think of like a police department. So the SCPD, if you Google it on the internet, is the County of Suffolk Police Department in New York. So we're not talking about that. I guess the first question is, what do we call this topic? And it's a bit controversial. Probably the most heard of, and what we call it mostly in Quebec, is BPSD or SCPD in French. Behavioral and psychological symptoms in dementia. But another term that's becoming more popular is responsive behaviors. And when I first heard about responsive behaviors, I didn't really know what people were talking about. Is this dementia? Is it not responsive? Who's responding? What's going on? We'll talk about that. It opens the subject of a conversation, which I think is really important. So one of the points or the themes of this presentation is that it takes two to tango, and we're talking about dementia and its effect on the brain, but we're also talking about people's environment And a behavior is a response of the brain to some kind of stimulus. Could be an internal stimulus like pain or an emotion, but it could also be an external stimulus, and often is in the environment. And that's what generates a behavior. And so that's essentially what we mean when we're talking about responsive behaviors, is that it brings in the idea that this isn't just about dementia in the brain, but a response to something that's going on, some kind of stimulus, which is important when we talk about how to treat it, especially going beyond drugs. So what is it when we encounter a behavior? First of all, behaviors are really important aspect and challenging aspect of dementia. They are one of the main reasons we see why people come into the emergency department, are no longer able to cope at home, lead to caregiver burden and distress, lead to distress in patients. So it's an important topic to deal with. They might be related to the dementia, but they also might be a long-standing behavior that has nothing to do with dementia, or now is occurring in the context of dementia, is worsened by the dementia. They might be related to an internal stimulus, like I said, pain, anxiety, depression, shortness of breath, some kind of symptom in the body. However, they are commonly a response to a stimulus in the environment in the context of a brain that's affected by dementia. So I guess when we think of behavior, the most common thing we think of is this: somebody who's agitated, angry, but although this is one of the more challenging aspects of behaviors and probably the one that's most studied in terms of treatments, when we talk about behavior and dementia, we actually have to talk about the full spectrum of issues and different kinds of things that could be considered behaviors that are not agitation or could be confused for agitation. A good example is someone who's calling out. We'll see the phenomenon of somebody, especially if they're alone, where they will call out and often say the same thing over and over again. Often it's help me, help me, help me, help me. You go into their room, they immediately stop. They're comforted by the presence of another individual. They can't really identify what it is that they want. You leave, and then they start calling out again. It's often mistaken for agitation, but it's not agitation. It's one behavior that's very hard to treat, doesn't respond to medications. But is a little bit different than what we talked about in terms of agitation. Another behavior, and one that is quite upsetting, especially to patients and family members too, is apathy. The loss of interest, the loss of enjoyment in activities that people used to like to do before. And it can be quite upsetting. It leads in part to some of what we call ambiguous grief. So you're grieving the loss of someone's personality and what they did, but they're still around. So apathy can be quite distressing, very different from agitation. Another example is hallucinations. So all kinds of different behaviors can occur. Here are some more detailed examples. We talked about calling out and aggression and hallucinations. People can have disinhibition, where they say things that most people would keep to themselves, but say it anyways. It's often inappropriate and can be upsetting, especially in social settings. It leads to isolation. Often people don't want to have friends around or go out because they're afraid what might be said. Resistance to care is a big one. People who need help now for things like bathing and dressing, but they don't realize they need help. And now there's someone coming to give them help that might be a stranger or somebody that they don't recognize, and they're resisting that help. Seeking attention. Even things like repetition. or searching for and losing things, which are more directly related to memory problems. You forget something that you said, or you forget the answer to a question, you repeat it over again. Wandering is a big one, where people are trying to leave a house that might not be familiar to them, or maybe they're searching for something, maybe they're hungry, they're looking for food, they don't know where to get it. There's many reasons why people wander. So there might be, like it's written there, a purpose, or they might be trying to find an exit. Delusions are beliefs in things that are not actually true. Sometimes they're very bizarre, like I've been abducted by aliens and I'm on a secret mission for the mother planet. Sometimes they're a little bit less bizarre, but just as distressing. So I think that my wife is cheating on me with a caregiver. Another thing that can be very upsetting is sexually inappropriate behaviors. And again, important to understand that sexuality does not end after a certain age. Sexuality is a normal part of life in people with dementia as well, but it may no longer be appropriate for the context of the situation and can be mixed up with things like disinhibition and that kind of thing, and can be very upsetting and can result in some very bad and challenging situations. So each behavior is very different. The treatment and approach to each behavior is different. The chance that medications are going to work or not is very different depending on all of these things. So it's important to figure out, and when somebody comes in with behavior problems, I'm trying to figure out exactly what it is that I'm dealing with. I want all the details about exactly what is happening so I can know how to find a solution. So before we move on, we're going to do kind of a recap of things that you might have heard in other talks, just because I think it's a good idea. We'll go through these quickly, but just to recall some terms that we might use and better define them. So when we talk about cognition, it means the way that the brain thinks, and there's many different aspects of that: memory, language, but behavior and emotions are sometimes considered a part of cognition as well. Someone who is cognitively normal has no difficulties with this other than with age, and there are some changes that happen with cognition with normal aging. Somebody with subjective cognitive impairment has difficulties, but we can't measure it on testing. Dementia is where people have cognitive problems that impact on functioning, which are progressive. Mild cognitive impairment is where people have cognitive problems more than aging that don't have an impact on functioning. Another term for these things is major and minor neurocognitive disorder. So major neurocognitive disorder is a synonym for dementia, and minor for mild cognitive impairment. The first really important point in the review of these terms is delirium. We are not talking about delirium today, but when we talk about behavior, we have to think about delirium. If there's a sudden change in behavior, especially agitation, brand new hallucinations, sudden worsening in cognition, periods of sleepiness, it is a warning sign that there could be delirium, which is a medical urgency. It means that you need to seek out a medical assessment. Could be if you can get in to see your family doctor right away, or sometimes going to the emergency room if necessary, or calling the doctor in the nursing home or the nurse practitioner who's covering to do an assessment to try to figure out what is the underlying cause, because delirium has an underlying trigger that leads to this temporary behavior and worsening in terms of disorganized thinking. It is different than dementia because it's reversible, but they often occur together. The brain is more fragile in someone who has dementia, more susceptible to delirium. And then they suddenly get worse, but once we treat the underlying problem, they usually get better. No, their dementia doesn't go away, but at least gets back to kind of what's more their usual function and behavior and memory. So delirium's often missed. Like I said, it's often missed and mistaken for other things. The important ways of distinguishing it from normal dementia are the sudden onset and the fluctuation, and then also very unusual to suddenly have hallucinations. Sometimes people can get hallucinations in dementia, but if they occur suddenly and are very bad, it's a red flag. So dementia is different from delirium in terms of it being progressive, and it's usually due to damage in the brain that comes from shrinking of the brain. It can also be blood vessel damage in the brain. And the symptoms vary a lot from person to person. Nobody's the exact same. And the progression too. Sometimes people get a lot worse in 2 or 3 years. Some people, it takes 10, 12 years to worsen significantly. So that can be challenging as well in terms of understanding what's going on. There are different causes of dementia, different things that cause the brain shrinking and different diseases that have different types of symptoms associated with them. And we should mention 2 types of dementia in this talk, where the behaviors that people have are very specific and a sign of a certain kind of underlying dementia. Everyone's heard of Alzheimer's disease, which is mainly a memory problem, but some people may not have heard of something called behavioral variant frontotemporal dementia. It's a mouthful, but it is one of the diseases that causes dementia, and it has very specific symptoms. And the behaviors that people get with that are a combination, not just one of these things, but several of these types of behaviors that include very specific things like binge eating and putting stuff in your mouth that's not food over and over again, severe apathy, a very severe lack of empathy, just not caring about anything at all anymore. So we've had people who their wives that they loved very, very much pass away and they don't even seem to care about it. So we're talking about severe changes in empathy, socially inappropriate behavior, and people with this diagnosis actually have pretty good memory. It's mainly a behavioral issue, and their main thinking problem is that they're disorganized and they can't solve problems. Okay, so it usually occurs in younger people, pretty unusual after the age of 80. In people with very early onset or early onset dementia before the age of 60, it's much more common. So if there are behaviors and they're exhibiting a few of these features, it's good to get an opinion, at least starting with a family doctor, and probably encouraging people to see a specialist to see if they might have this. The treatments, the prognosis is very different than Alzheimer's disease, and so it really needs that specialized medical attention. Behavioral variant frontotemporal dementia is caused by shrinking at the front of the brain. This is a brain. All the wrinkly material in the middle is the brain tissue, and surrounding it, the circles are the skull and the scalp. And you can see there's more shrinking at the front of the brain, which is where these behaviors arise from, the shrinking in the front part of the brain, which is important for regulating behavior. Another important dementia that can cause very specific behavioral symptoms is Lewy body dementia. Again, it's different than Alzheimer's disease. And the behavior that people get with this are hallucinations. It's pretty unusual in Alzheimer's disease and typical causes of dementia to have hallucinations early on in the early stages. And so if that happens, you could have Lewy body dementia, but you have to have some of the other symptoms that go along with it as well, like Parkinson's type symptoms, or this sleep problem where you move in your sleep or talk out in your sleep. Lewy body dementia is sometimes hard to distinguish from delirium, the main thing being that it doesn't occur all of a sudden. It's slowly getting worse. But like delirium, it can fluctuate, where people have a lot of days where they seem to be normal, days where they're a lot more confused. So again, if you think that your family member with dementia, or someone you know, or you're having these symptoms that are different than what you would expect with Alzheimer's disease, and hallucinations are a part of it, again, it's important to seek out some medical help. And again, the prognosis and the treatments are very different and specific for the behaviors associated with this kind of dementia. It's important to talk about, and we're going to be touching on this later, that dementia goes through different stages. Early stages where people don't even have symptoms, but the disease process is starting to happen in the brain, to where the symptoms are present, but they don't impact on functioning. And then the mild stages where it's impacting on more difficult things like driving and cooking, and the moderate stages where it's people are starting to need reminders to change their clothes and get dressed, severe stages where people need help with their personal care, and very severe stages where people start to not be able to walk and talk and need help eating. So that's important in behavior, talking about behavior as well, because the behaviors can change through those different stages of dementia. 90% of people with dementia will develop some kind of behavior or another, and aggression is the one that is most often what we're trying to address in the clinic when people are coming in looking for help. It's much more common in nursing care or retirement facilities, still very common in the community, but a little bit less so. Like I said, it has a big impact on people's quality of life, and often is the trigger for needing to move from living independently into a facility. You can see here that as dementia progresses in terms of time and goes through the different stages, the behavior, no matter what we're talking about, it could be hallucinations or delusions or apathy or irritability or agitation, they all increase, becoming more and more common as time goes on. So we talked a bit about behavior in dementia, the different types of behaviors that occur and how they can increase over time. Now we're going to talk about how to treat them. And the first thing I want to cover is medication. So one thing that you can try to do is try to fix the brain, that big brain picture that we saw. All these dots represent medications and trials that have been used to try to cure dementia, cure Alzheimer's disease. And in the target in the middle are the ones that have actually passed all the trials and made it to market. And these are the 4 medications that we have that actually try to improve people's thinking and memory problems. Unfortunately, they do not have much evidence for helping with behavioral problems in particular. Sometimes in some conditions like Lewy body dementia, they can help with hallucinations, but they're not particularly good for things like agitation. These medications are called cholinesterase inhibitors, and people may know people who are on them, and they are good drugs for trying to slow down the progression of thinking problems. The drugs that we use for treating behavior symptoms are quite a number of different medications, and this is a list of all the things that have been tried. And unfortunately, the reason we have so many medications that have been tried is because none of them are especially effective. There's no medication that I can put a patient on and guarantee that their behavior problem, their agitation, their aggression is going to go away. Certainly, there's evidence that they can help. And I would say probably about half of the time, I can be confident that starting someone on an antidepressant or an antipsychotic type of medication is going to help with their symptoms about half the time. But I have to be careful with my patients and families to manage their expectations and have them know that sometimes we have to try 2 or 3 different medications, or we may not find a solution through medications at all. But sometimes symptoms, especially agitation, can be very dangerous and very distressing, and we do have to move to a trial of medications, and there is good evidence that they can be effective. The main things that we use are a class of medications called antipsychotics, as well as a class of medications called antidepressants. And the main ones we use are medications called risperidone and olanzapine as antipsychotics, or sertraline or citalopram as antidepressants. So the question that I'm going to put out there, and I'm not going to answer it, I'm just going to put out there, is why do we not have a cure for dementia yet after all this research? Why do we have treatments for behavioral symptoms that are only partially effective with side effects that can be concerning as well, where people often have to stop them due to concerns about side effects after discussing them with their doctor? Why is there no magic pill that I can start? And I think that's important too to mention, is that, you know, and nobody has the magic pill that's going to fix all of these problems. So I don't have an answer to that question, but I'm going to explain to you something that I have certainly, and many people have observed, is that in dementia, especially with behavior, people can have that one day where they're just doing fantastic. They're happy. They seem to remember things that they didn't remember before. They just have a fabulous day. And alternatively, they can have a bad day where things are just particularly worse for some reason, and we're not entirely sure why that is. If there was a medication that could make people have more of those good days and less of those bad days, we would certainly prescribe that. We don't notice this kind of dramatic effect with the pills that we prescribe to people. So what is it about these good days and bad days? And I would suggest that it often has to do with things in the environment. It's that one particular caregiver that they like who just has the magic touch. It's that day of the week where the family member visits. It's a particularly bright or sunny day where the weather's really nice outside, or where there was an excursion, or where someone came and played music that they liked. Those are the things that seem to make more of a difference, in my opinion, than any medication ever could. And to illustrate this, I want you all to watch this video. I think it illustrates this principle very nicely.
Hi, Papa. Hi, Papa.
Huh?
How you doing?
I'm all right. I'm fine.
Who am I?
I don't know. Wait a minute. I don't know.
Okay, it's Cherry.
How long has he been in the nursing home? Approximately 10 years.
10 years.
He was having seizures, and my mother couldn't handle him at home. Of course, it affected me greatly because he was always, fun-loving, singing, every occasion he would come out with a song, no matter where he was. I remember as a child, he used to walk us down the street, me and my brother, and he would stop and do Singing in the Rain. He would have us jumping and swinging around poles. He was, he was good. He was always into music, always loved singing, dancing.
His name is Henry Dreyer.
Uh-huh.
And I'm looking more or less for religious music for him.
Okay.
Because he enjoys music and he always quoting the Bible. So I'd rather have that for him.
We first see Henry inert, maybe depressed, unresponsive, and almost unalive.
Henry.
Yeah?
Henry.
Yes, sir.
I found your music. You want your music now?
What's up to you?
Okay. Let's try your music, okay? And then you tell me if it's too loud or not.
Then he is given an iPod containing, we know, his favorite music. And immediately he lights up. His face assumes expression, his eyes open wide. He starts to sing and to rock and to move his arms, and he's being animated by the music.
And he used to always sit on the unit with his head like this. He didn't really talk to much people. And then when I introduced the music to him, this is his reaction ever since.
The philosopher Kant once called music the quickening art, and Henry is being quickened, he's being brought to life.
Yeah?
I'm going to take the music for 1 second, okay? Just to ask you a few questions. Okay? I'm going to give it back to you.
Uh-huh.
Okay.
The effect of this doesn't stop, because when the headphones are taken off, Henry, normally mute and virtually unable to answer the simplest yes or no questions, is quite voluble.
Henry,
Yeah?
do you like the iPod? Do you like the music you're hearing?
Yes.
Tell me about your music.
Well, I don't have one, I mean.
Do you like music?
Yeah, I'm crazy about music. You play beautiful music, beautiful sound. Beautiful.
Did you play music when you were, did you like music when you were young?
Yes, I went to big dances and things.
What was your favorite music when you were young?
Well, I guess, Cab Calloway was my #1 band guy I liked.
What's your favorite Cab Calloway song?
Oh, I'll be home there for Christmas. Oh, you can count and plan on me with plenty of snow, mistletoe, present wrapped around your tree. Ow!
So in some sense, Henry is restored to himself. He has remembered who he is, and he's reacquired his identity for a while through the power of music.
What does music do to you?
Give me the feeling of love, romance. Figure right now the world needs to come into music, singing. You got beautiful music here. Beautiful, oh, lovely. And I feel the band of love, the dream. The Lord came to me, made me holy. I'm a holy man. So he gave me this sound. I'll just say, I meet you. Let me see. Rosalie, won't you love me? Rosalie, won't you be sweet and kind?
With this beautiful new technology, you can have all the music which is significant for you in something as big as a matchbox or whatever. And I think this may be very, very important in helping to animate and organize and bring a sense of identity back to people who are out of it. Otherwise, music will bring them back into it, into their own personhood, their own memories, their own autobiographies.
So after thinking about this, I started to understand, I hope that you can understand too, why people are suggesting that instead of calling these behavioral and psychological symptoms of dementia, that we focus less on the dementia and less on the brain and more on people's environment. The environment is something that we can certainly try to change, and we can try to adapt to the individual to give them a better experience and quality of life. So we're going to cancel the police, and we're going to think about improving the environment. So what are some simple psychological interventions that we can think of? So I would suggest that if the symptoms of behavior are not particularly distressing or dangerous, we consider not using a medication as what we call a first line. And that it's important to think of that because, first of all, a lot of these symptoms will spontaneously resolve. They'll get better on their own. And they can often not cause much distress. I have some people who come in complaining of hallucinations, and they're looking to treat the hallucinations, but then when I ask them about the hallucinations, they're not particularly bothersome. They may even enjoy having the hallucinations. And so sometimes you have to decide whether or not this is something that you have to treat. On the other hand, sometimes the hallucinations are very distressing and we have to do something about it. So think about not jumping to medication right away. The first important thing is to try to figure out already what we know from observing carefully, what things tend to trigger this behavior and what things tend to help with the behavior. And a lot of people, when they take some time and think about it and we work through it together, can figure out these things. And this is the first thing that we use to try to treat. Is there a time of day? Is there a noise? Is it around personal care that we're trying to give? Is it always having to do when they have to take a bath and they don't want to take a bath? Is it pain that they're having a hard time expressing? Are they hungry? Are they restrained in some way that may not be necessary, that's actually making things worse? There's been quite a few times where I had a restrained patient who was agitated, and they're restrained because they're agitated, but they're agitated because they're restrained. And all we have to do is take the restraint off and it fixes the problem. We try to not use restraints at all because of this issue, except in very exceptional circumstances. And then you may notice that certain things help, being distracted by an activity that people like to do, trying to redirect people, get them from stopping to think about or behaving on the issue that is bothering them, and try to get them to do something that that is less upsetting. Reorientation, sometimes giving them a prop, a stuffed animal, a fidget board with knobs and screws and things that they're not going to hurt themselves with, that's going to preoccupy their time. Or sometimes just simply going for a walk and moving around. All these things can be successful factors that have helped. And if you can identify them, then you know those are the things that you can try to do more of. It's quite time intensive, and it can be difficult for a caregiver who is already burnt out. So think about help that you can recruit to try to make these things easier as well. Things like day programs, that's a big thrust behind these types of activities, and that can give people a break. The other thing that is that sometimes the behavior is, again, a manifestation of an underlying medical problem. So much the same as delirium, if it's challenging, if it's occurred all of a sudden and you're suspecting that there might be some underlying medical issue, it might be appropriate to consult your nurse or doctor to try to figure out what that might be. Sometimes giving someone their glasses or hearing aids. Sometimes it's that they're dehydrated or they have an infection, or sometimes it's important to realize that some medications, although we use them to help behavior, sometimes they can make it worse as well, and they may need to be adjusted. So it is reasonable to, in some circumstances, get some help from a medical practitioner. Pain deserves special attention. It is a very common trigger of behavior, and people with dementia do not necessarily communicate that they have pain in the same way that they do before, or are as easily able to look after it. They might not be able to walk or move around to help them get a more comfortable position. They might not be able to go to the medicine cabinet and take the Tylenol. They might not be able to ask for it. And so sometimes just putting somebody on regular Tylenol can help with agitation, even if they're not explicitly going out and complaining of pain. So this is a slide. I know the print's small, but if you're watching from home, you can blow it up and look about many of the different kinds of triggers that have been identified as causing agitation. And for the interests of time, I will not go over all of those individually, but you can look at it yourselves. What are some strategies that have been tried from a medical point of view, other than medications, specifically to help with behavioral symptoms? I'm not going to talk about all of these. I'll talk about some of the ones that I really like because they're fun and interesting and effective. Reminiscence therapy. People with dementia often have very good long-term memory, and they can enjoy talking about experiences and things that happened in the past. Get a photo album, go over it with them. Take some recordings where they tell a story about something interesting that happened in the past. And this is an activity that people will do that they enjoy, and often can help prevent behaviors. And they might tell the same story over and over again, but that's okay if they really enjoy sharing that memory. That can be a very therapeutic thing. Even things like aromatherapy, exposure to light can make a big difference. Think about people often sitting in the dark in a stretcher in a room. That's actually not very good for the brain. Sometimes sitting outside or by a bright window can make a big difference. And then we also have to look after the caregivers. This is very important. A caregiver who is burnt out and stressed and at their wits' end, patients with dementia, and especially if they have difficulty with their behaviors, they're going to pick up on that, and they're going to feel distressed and anxious as well. And so we have to help our caregivers get the relief they need, cope with stress and anxiety, and find successful ways in order to look after themselves. If you can't look after yourself, you can't look after the one who you're caring for. This is very, very important. So we're not going to talk about research and studies, but just to say that there is less research that goes on to non-medication strategies. There's a little bit less of an industry, drug industry pushing them. But there is evidence from a medical point of view that these types of strategies are probably as, if not more effective at treating behaviors than medications in many cases. So I think of when somebody comes in with behavior to my clinic, this is my thinking flow diagram in terms of how I approach the problem. The first thing, and I suggest this as a way of thinking that everybody can use, and it'll help you understand when to seek out help from a doctor and medications, or when you might want to instead talk with a consultant who has expertise in dementia, or call the Alzheimer's Society, or get some ideas from a support group or that kind of thing. So the first thing I want to do is try to define the behavior. What is it exactly that we're dealing with? Is it actually agitation and aggression, or is it something else like apathy or hallucinations? That's very important. Then we need to know, is this severe or hazardous, or is this something that we can wait and try to see if it gets better on its own, or try some interventions that don't involve starting a drug or a medication right away. If it's severe or hazardous, that's when you have to seek help from a nurse practitioner or doctor, and obviously as soon as possible, and where we might use a medication like an antipsychotic. But we're also not just using drugs, right? We also want to push using drugs at the same time as these other strategies, right? If the strategies or the behaviors persist and the strategies are ineffective, then we might consider medications. And then the other important thing with medications and behaviors is knowing that if and when it gets better, if it's not effective, stopping them, because there's some harm in being on these medications in the long term. If the behavior issue has resolved, the medication has been effective, it's done its part. Sometimes it's worthwhile trying to see if it can be slowly brought down, always in consultation with the person who prescribed it, or a physician in the first place. Okay, and that's my approach. That's how I think about an approach and try to understand a patient who I am trying to help with behavioral symptoms. So are there any questions?
Dr. Doell, thank you for such a thorough presentation. I think that's one of the most educational presentations I've seen on managing and understanding responsive behaviors. Just a couple of questions. First of all, we know that during the COVID pandemic, a lot of families have been isolated. Family or informal caregivers have not had the necessary education or tools needed to know how to manage the behavior. You mentioned earlier, for instance, these day programs, they've stopped because people can't go in person anymore. Home care resources have also stopped in many cases. What have you seen in terms of how the pandemic may or may not increase challenging behaviors in people with dementia?
Thanks, Claire. This is such a good question and so pertinent, and I think it really illustrates one of that principle that I was trying to make. We've had a pandemic of COVID, but we've had a pandemic also of worsening quality of life for people with dementia, change and worsening of distressing behaviors, even people's cognitive decline accelerating because of what's going on. And I think it really illustrates that their brain hasn't changed, right? But their environment has changed, and their caregivers are more stressed out, and people pick up on that. People have lost the resources that they have. That family member who could help out, who can't visit anymore because of a lockdown. The help from the CLSC that's not coming anymore because of the lockdown. The lack of activity, the lack of going out, the lack of familiar people and people's environments, all of that has made a big change. And people try to find ways to adapt. using videos for visits. And, of course, we've tried to spend more time outdoors where it's a little bit safer. But that can be certainly difficult and challenging, but people do find ways to adapt. Unfortunately, a lot of the technological ways to adapt for connecting with people, because socialization is so important. These are difficult for people with dementia who can't use phones and computers. So, we try to get by the ways we can. And fortunately, now that life is slowly returning more towards normal, it's important to realize that the effects of the isolation, try to resume some of those activities that were beneficial and to advocate for them, right? We need to advocate for the day programs to start up again because they're so important when we can. Certainly there's safety in isolation, but there's danger in isolation as well. And it's important to try to find that balance.
I work with a lot of family members, and I I use the term a lot now, pick your battles. Sorry, pick your battles, where 24 hours, 7 days a week is a long time to be with a person, especially for those caregivers who don't have any support. And, you mentioned earlier how, in some cases, some of the, for instance, hallucinations may actually be giving pleasure to somebody. And I think that, one key point for caregivers is, if what the person is doing is not endangering themselves or endangering others, just let it go. I think, like, for the person with dementia who decides to change their clothes 5-10 times a day, or decides wandering around the house pacing at some point, if that is actually, it's not hurting themselves, it's not hurting anybody else, just let them be. Because I find that one of the causes often of the challenging behavior is when the care partner is constantly nitpicking and everything, like, stop doing that, stop touching this, why are you doing this, like, why are you changing your clothes? And I think it causes a lot of, like, arguments. I mean, as in healthy couples, right, where you're living with your kids and your husband constantly under the same roof, and everybody just starts noticing everybody's faults, right? So I think a good strategy would be really to also just pick your battles.
Picking your battles is very important. It's also important to realize sometimes if there's a lot of little things that are bothering you, it can be a sign of burnout and caregiver fatigue, and where you might need to start to look for some help as well. The stress of the caregiver and the behavior of the patient is so intertwined, right? I think trying to make a priority in terms of what's going on and what's most important. Somebody who's playing with knives, requires an intervention. Somebody who's refusing to take a bath, it's certainly not optimal, but it's probably not going to kill them or anyone else. If the bath is once every 2 weeks instead of every day, depending on the circumstances, certainly sometimes if people are soiled or incontinent, they might need to be cleaned more often. But it's a change in the routine. It's a change in life. And it's gonna cause a change in how we approach things, and focusing on what's more important. Trying to put yourself. I find I do this as well. I try to understand what's happening in someone's brain with dementia and what their experience must be like, what their environment must be like when they don't remember what happened 5 minutes ago. So, like, for example, the bathing issue, right, where people are resisting bathing. What must it be like where you don't think that you need help to bathe, and suddenly a stranger who you don't recognize is coming at you and asking you to take your clothes off and take a bath? I tell people, how would you feel if a stranger barged into your home and, asked you to take your clothes off and take a bath, you'd probably react in a not too favorable way. So it can sometimes be a good exercise to step back, put yourself in their shoes to try to understand why this is happening. That can kind of help you learn some strategies. Maybe with the bathing thing, you have to ease your way into it. Maybe there's every visit, some familiarity and a rapport that needs to be developed, or you have to figure out what routine that person had. Maybe they had a routine before the bathing that worked them, up to that. Maybe they folded their towels, or maybe they were used to taking a bath and not a shower, and now we're trying to get them to take a shower and it's not going well. So those are the kinds of things in terms of picking your battles and figuring out your approach. It does involve taking a step back rather than just reacting, which is hard to do when you're burnt out, but it's important in order to help improve the situation.
Well, I really feel that, the one of the best prescriptions is really education, knowledge, especially on the part of the care partner, to understand what is happening, why is it happening. And thank you so much for taking the time today to be with us and to give us such an incredibly thorough presentation, which I have no doubt will benefit so many family caregivers. So thank you very, very much for taking the time today.
Thanks, Claire. Thanks for having me. It's my pleasure.
Thank you. Well, this webcast is an initiative of the McGill Dementia Education Program, which is funded by private donations. Once again, I would like to sincerely thank the Zeller Family Foundation for supporting today's webcast. If you would like to make a donation to our program or for more information, please visit us at mcgill.ca/dementia. And if you would like to know more about what's coming up with regards to McGill Cares webcasts, program information, or other important initiatives that we're doing, you can email us at dementia@mcgill.ca. Thank you for watching.